Gynecomastia Franklin C. Babb, M.D. FOF Basics Description: benign glandular proliferation of male breast tissue. Increase in estrogen activity relative to androgen leads to the development of gynecomastia. Gynecomastia can be transient and may represent the normal physiologic changes that occur in utero or in adolescence. However, gynecomastia presenting or persisting in adulthood is typically pathologic in nature. Pseudogynecomastia, which is lipomastia, subareolar fat. Epidemiology: 60–90% of infants have transient gynecomastia. 1. 50–60% of pubertal males have mild transient gynecomastia. Onset at 10 to 12 years of age and resolution by age 18 years in most individuals. 1. Up to 70% of men between 50 and 69 years of age report gynecomastia. 1. Incidence: a study out of Bulgaria in 2007 put the incidence of pubertal gynecomastia at 3.9% in Caucasian boys ages 10–19. 2. Etiology and pathophysiology: increase in estrogen activity relative to androgen activity leads to the development of gynecomastia. Estrogen stimulates ductal cell hyperplasia, facilitates ductal branching and lengthening, increases vascularity, and results in the proliferation of periductal fibroblasts. These changes occur within 12 months and are followed by fibrosis in the later stages of gynecomastia. Multiple factors can alter the estrogen to androgen ratio and precipitate gynecomastia: decrease in androgen production, increase in estrogen production, increase in peripheral conversion to estrogen, inhibition of the androgen receptor, increase in the level of sex hormone binding globulin, SHBG, or the affinity of androgens to SHBG, decreases free or bioavailable testosterone, displacement of estrogen relative to testosterone from SHBG due to medications. Risk factors: gynecomastia can be physiologic or pathologic in nature. Physiologic: gynecomastia presents in infants and adolescent boys and resolves spontaneously. Neonatal gynecomastia: the placenta converts dehydroepiandrosterone, DHEA, and dehydroepiandrosterone sulfate, DHEAS, to estrone and estradiol, resulting in transient gynecomastia. Adolescent gynecomastia: transient increases in estradiol levels at the onset of puberty lead to gynecomastia. Pathologic gynecomastia refers to persistent or adult-onset gynecomastia. 25% of cases are idiopathic in nature, most likely secondary to age-associated decline in free testosterone and adipose tissue-mediated aromatase activity. Multiple medications have been implicated. 1. Alert: illicit drugs, marijuana, heroin, methadone, alcohol, amphetamines, and over-the-counter bodybuilding supplements, hormones, androgens, anabolic steroids, estrogens, estrogen agonist, and human chorionic gonadotropin, HCG, anti-androgens or inhibitors of androgen synthesis, bicalutamide, flutamide, nilotamide, cyproterone, and GnRH agonists, leuprolide and gosrelin, anti-infectives, metronidazole, ketoconazole, minocycline, isoniazid anti-ulcer medications, cimetidine, ranitidine, metoclopramide, and proton pump inhibitors, cytotoxic agents, methotrexate, alkylating agents, and vinca alkaloids, cardiovascular drugs, digoxin, spironolactone, calcium channel blockers, ACE inhibitors, amiodarone, methyldopa, reserpine, minoxidil, and recently statins can be added to this list. 3. Psychoactive drugs, antidepressants, benzodiazepines, phenothiazines, antipsychotics, typical and atypical, i.e., haloperidol and risperidone, medications, HIV medications like efavirenz, phenytoin, penicillamine, solindac, or theophylline. Causes to rule out: primary hypogonadism, androgen insensitivity syndromes, defect in the androgen receptor, Klinefelter syndrome, testicular tumor, germ cell, secretes HCG, Leydig cell, secretes estrogen, Sertoli cell, excessive aromatization to estrogens, adrenal tumors, secrete DHEAS and estrogens, ectopic HCG tumors, hepatoblastoma, gastric tumors, renal cell carcinomas, cirrhosis, secondary hypogonadism, Kallmann syndrome or Prolactinemia, which can also stimulate milk production in breast tissue. Hyperthyroidism, renal disease or dialysis, malnutrition/starvation. Rare, true hermaphroditism, both testicular and ovarian tissue present. Pediatric considerations. Transient gynecomastia is seen in neonates or pubertal boys, typically resolves within 6 to 24 months. Geriatric considerations. Age-associated decline in testosterone production and increase in SHBG production leads to low free testosterone levels in the elderly population. Furthermore, the increased ratio of fat mass to lean mass noted with aging leads to adipose tissue-mediated peripheral conversion of androgens to estrogen. Medications also play a significant role in the development of gynecomastia in this population. Commonly associated conditions. Prostate carcinoma, treatment with estrogen and anti-androgen leads to gynecomastia in 75% of patients. Cirrhosis. Primary hypogonadism, especially Klinefelter syndrome, congenital abnormality, leads to primary hypogonadism and gynecomastia. These patients are at risk for breast cancer and need regular breast exams. Testicular tumors, Leydig or Sertoli cell tumors, especially when associated with Peutz-Jeghers syndrome or Carney complex. Diagnosis. History. Inquire about duration of breast growth, increase in breast tissue size, and associated breast pain and discharge. If suspicious of hypogonadism, ask about erectile dysfunction, muscle mass, and decreased shaving frequency and libido. Obtain a complete medical history including headache, loss of vision, loss of appetite, weight loss, malignancy, thyroid disorders, liver disease, renal disease, and genetic abnormalities. Obtain a family history including Carney complex and Peutz-Jeghers syndrome. Review medication list extensively and inquire about the use of illicit substances. Question about herbal supplements, marijuana use, and over-the-counter cimetidine, Tagamet, or other H2 antagonist use. Physical exam. Careful breast exam to evaluate characteristics: firm, concentric glandular tissue beneath the nipple and areola palpable by pinching the thumb and forefinger together from either side of the breast toward the nipple. Diameter of this tissue for diagnostic purposes ranges from greater than 0.5 cm to greater than 2.0 cm, but the most recent large study recommended 1 cm as the diagnostic criteria. 2. May involve one or both breasts, usually asymptomatic, but may be painful or tender if it is of recent onset. Off-center, hard, fixed mass is concerning for malignancy, although palpation of subareolar fat is more consistent with pseudogynecomastia. Breast discharge should raise concern for malignancy or prolactinemia. In the latter, the discharge is typically clear or milky. Thyroid exam. Evaluate for diffuse enlargement and palpable nodules and check extremities for tremor and brisk reflexes. Abdominal exam. Evaluate for masses and liver size. Genitourinary exam. Evaluate for testicular size, hair pattern, and presence of ovary or uterus. Visual field exam. Evaluate for peripheral field defect. Differential diagnosis. Pseudogynecomastia, fat deposition without glandular proliferation, often seen in obesity. Breast cancer. On exam, the lesion is typically unilateral, firm, eccentric to the nipple, and associated with skin dimpling, nipple retraction/discharge, and lymphadenopathy. Lipomas. Sebaceous cyst, dermoid cyst, mastitis, hematoma, hamartoma. Diagnostic tests and interpretation. Laboratory and radiologic investigations should be tailored to fit history and physical exam findings. Idiopathic gynecomastia is a diagnosis of exclusion, and therefore, laboratory tests to rule out medical conditions associated with gynecomastia is recommended. Initial tests: lab, imaging, luteinizing hormone, LH, elevated in primary hypogonadism and decreased in secondary hypogonadism. Morning total and free testosterone. Decreased testosterone level in hypogonadism. HCG elevated in germ cell tumors and ectopic HCG tumors. Estradiol elevated in Leydig cell tumors, Sertoli cell tumors, adrenal tumors, and with increased aromatase activity. DHEAS levels, which can be increased in adrenal tumors. Urine for drugs of abuse, UDA. Other tests to consider include creatinine, liver function test, thyroid function tests, and prolactin. Follow-up tests and special considerations: consider imaging studies based on laboratory findings. Testicular ultrasound, testicular tumor, chest X-ray, CXR, and abdominal computed tomography, CT/magnetic resonance imaging, MRI, extragonadal germ cell tumor, ectopic HCG tumor, and adrenal tumor, MRI of pituitary tumor, diagnostic procedures/other based on physical exam findings. Consider biopsy of breast mass to rule out malignancy, i.e., off-center, hard, fixed, discharge. Test interpretation: elevated HCG, check testicular ultrasound. If positive for a mass, likely a testicular germ cell tumor. If the ultrasound is negative, consider extragonadal germ cell tumor or HCG secreting neoplasm and order a CXR and CT abdomen. Elevated LH, if in relation to low testosterone, likely primary hypogonadism. If elevated in relation to high testosterone, check thyroid stimulating hormone, TSH, and free thyroxine, FT4. If FT4 is elevated and TSH is suppressed, likely hyperthyroidism. If TSH and FT4 are normal, likely androgen resistance. Normal or decreased LH in relation to low testosterone, check prolactin level. If prolactin is elevated, likely due to a prolactin secreting pituitary tumor. If normal, likely due to secondary hypogonadism. Normal or decreased LH in relation to increased estradiol, check testicular ultrasound. If positive for a mass, likely Leydig or Sertoli cell tumor. If negative for mass, check CT abdomen to evaluate the adrenals. If mass is present, possible adrenal neoplasm versus adenoma. If no mass is detected, then likely due to increased aromatase activity in extraglandular tissue. HCG, LH, testosterone, and estradiol are normal, likely idiopathic or medication/drug-induced gynecomastia treatment. General measures: gynecomastia usually regresses spontaneously within 6 months of onset. This is true even for adult males. Therefore, patients can be monitored for the first 6 months and treatment considered if gynecomastia persists. The histologic changes early in the disease process can be reversed with medical therapy. However, with the development of fibrotic tissue, surgery is typically required. Typically, 1 to 2 years after the onset of gynecomastia, fibrotic changes can be seen and medical intervention is less effective. Neonatal and pubertal gynecomastia spontaneously resolves within 6 to 24 months. Persistent pubertal gynecomastia, greater than 24 months, occurs in 8% of pubertal boys. In adult males, 75% of gynecomastia is secondary to persistent pubertal gynecomastia, medications, and idiopathic conditions. Only 25% is related to an underlying medical condition. All illicit drug use and offending medications should be stopped if appropriate and patients monitored for clinical improvement. Underlying medical conditions need to be treated, i.e., testosterone replacement for hypogonadal men, dopamine agonist for prolactinoma, appropriate treatment for thyrotoxicosis, and tumor resection. Medical and surgical therapy to reduce gynecomastia should be considered in patients with significant physical or psychological discomfort. Medication: there are no Food and Drug Administration approved medications for the treatment of gynecomastia, but clinical trials involving selective estrogen receptor modulators, SERMs, and aromatase inhibitors demonstrate partial regression and symptom relief, i.e., breast tenderness. SERMs, clinical trials of both tamoxifen, 10 to 20 mg/day, and raloxifene, 60 mg/day, showed partial reduction in pubertal gynecomastia in 90% of study participants after 3 to 9 months, but 40% of patients in both treatment groups were not satisfied with the final results and underwent surgical removal. Tamoxifen has also been shown to reduce breast tenderness and prevent the development of gynecomastia in prostate cancer patients on androgen deprivation therapy. Therefore, SERMs, particularly tamoxifen, can be considered in men with 6 to 12 months of severe, painful gynecomastia symptoms. 4b. Aromatase inhibitors block peripheral conversion of androgens to estrogens. In prostate cancer patients, anastrozole prevented the development of gynecomastia in patients undergoing androgen deprivation therapy. Issues for referral: refer patients to an endocrinologist if abnormally elevated hormone levels are confirmed. If patients have refractory gynecomastia despite medical therapy and have prolonged gynecomastia characterized by the late fibrotic stage or symptoms concerning for breast cancer, referral to a surgeon would be appropriate. Additional therapies in clinical trials: prophylactic radiotherapy, 10 to 15 GY in 1 fraction over 3 days, prevented the development of gynecomastia in prostate cancer patients on androgen deprivation therapy. Higher doses, 20 GY in 5 fractions, improved pain symptoms in the same population. 4b. Surgery/other procedures: surgery to remove breast tissue is recommended if gynecomastia does not regress within 12 months either spontaneously or after medical therapy. Significant discomfort, i.e., pain, tenderness, causes embarrassment or anxiety. Biopsy suspicious for malignancy. Ongoing care. Follow-up recommendations: patient monitoring every 3 to 6 months for 24 months. Consider medical therapy, i.e., tamoxifen, if severe, painful symptoms persist after 6 to 12 months, and surgery after 12 to 24 months. In individuals with asymptomatic or mild disease, routine yearly breast and physical exam is recommended. Patients with Klinefelter syndrome are at increased risk of breast cancer and should have routine breast exams done. Patient education: patients should be encouraged to do periodic breast examination and to alert their clinical provider if a nodule is palpated in the breast or axilla, skin discoloration occurs, or nipple discharge develops. Prognosis: good in physiologic cases because they often regress spontaneously within 3 to 6 months. Majority of patients experience regression once underlying disorder is treated or offending agents are eliminated. The majority of patients who undergo surgery are satisfied with the postoperative cosmetic appearance.